This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
So welcome everyone to the last Psychiatry Academic Seminar Series for the year. It's the fifth one since it's been revamped, and thanks everyone for attending. And thank you to Dr. Sarah Farrand, who has kindly agreed to give us a talk on deep brain stimulation for OCD, an update. Sarah is a psychiatrist, neuropsychiatrist at the Royal Melbourne Hospital, also works a number of other places, including the Epworth, and has been is overseeing the deep brain stimulation for OCD program, which was developed, I think, in 2010 by Dennis Velakoulis and Andrew Evans, neurologists. So what I might do is mute myself and stop the video so we can all focus on Sarah, and we'll work out the questions in the end if people can put their questions in the Q&A section. Sarah, are you able to see the Q&A? You can, so you might be able to answer them as they go. So over to you. Thank you.
Thanks, John. Thanks for having me. So today, just going to give you a bit of an update on deep brain stimulation as it applies to OCD. Here we go. I guess by way of brief background, so OCD is a really disabling psychiatric disorder. The prevalence across people's lifetimes is about 1 to 2%. And it can be pretty devastating if it's not treated. So, you know, we occasionally see people coming into care for other reasons who've never had treatment for their OCD, and they, you know, often not leaving the home, you know, not working, living with parents still, that sort of thing. So it can be pretty devastating. Even when we do treat OCD, often the best available treatment only reduces symptoms by about 40 to 60%, and up to 10% of people, even with good going treatment, remain treatment resistant. So there are lots of evidence-based treatments we can use in OCD. So the main things are SSRIs and therapy, much like everything in psychiatry. But even though there's fairly good going evidence for use of SSRIs and also tricyclics like clomipramine, even the original studies looking at those really offer about a 40% reduction in symptoms, which you can imagine, you know, if you've got a very severe illness, that's not really sufficient. Therapy works about the same. So there are a number of psychological treatments that work for OCD, including CBT, but also exposure and response prevention and others. So you get, you know, a decent reduction, but it's often not enough. There is also evidence for using atypical antipsychotics. So people would often augment with things like risperidone, haloperidol, olanzapine. And even though that's well supported by randomized controlled trials, actually when you look at how much that reduces people's symptoms, it's only about another 10%. And so DBS, even though it's traditionally been seen as the treatment of last resort, even in either have this degree of reduction in symptoms or perhaps none at all, can still offer then a further benefit, so a further reduction, another 40 to 60%. And so certainly something worth considering for people. So DBS actually, I guess, sort of electrical stimulation as a treatment more broadly actually harks back a pretty long way. So this is the torpedo fish, or an electric ray fish, which back in sort of 49 AD, the physicians to the Roman emperor would use this as a treatment for things like pain, depression, epilepsy. And what they would do is actually put this fish, which delivers shocks, onto people's heads. And they actually found that that was quite beneficial for various sort of psychiatric and physical ailments. But I guess we've sort of evolved somewhat since then, although some might argue not particularly. But really, I guess where DBS has evolved from in more recent times is looking at some of the older psychosurgeries, so leukotomies and things, which were, you know, pretty big surgeries and caused a lot of damage to the frontal lobe circuits. But certainly those procedures did work for OCD, and people did get improvement. And the other things we've seen is that in deep brain stimulation for other indications, Tourette's, Parkinson's disease, is that you do get improvements in mood and anxiety. And so there was sort of these thoughts about, well, perhaps DBS might be helpful in OCD. And so that was, I think the first cases were reported in 1999. And there's been, a reasonable body of literature since then to support its use. So there are lots of different targets we use in DBS, and it really depends what you're trying to treat. The main sort of indications are movement disorders, and then in psychiatry, OCD is really the main one. There has been some DBS in depression, which has been pretty underwhelming overall, despite sort of some initial promise. And there's also, some experimental use in eating disorders, addiction, and then also in pain and epilepsy. I'll talk a little bit more about the targets for OCD in a sec. So in terms of thinking about what deep brain stimulation is and how that actually looks like for people, so there are different components. You can see here there's a battery pack in the chest, so that little that little box in the chest wall there. So that has the sort of is where we connect to program the device. It also has the battery, and that's connected via leads that are tunneled under the skin that go up and connect to the actual leads via a little sort of almost like a little bottle cap that holds the lead into the skull. And so when people are having this surgery done, obviously initially there's quite a lot of planning done about how we're going to get the lead into the target. That's obviously placed intraoperatively. Nowadays that's done asleep most of the time, which is great for patients. And then it's attached to that little cap on the skull, and then the leads are burrowed under the skin and attached to the battery pack. In OCD, there's a number of targets we can use. They all pretty much have pretty similar evidence. So the nucleus accumbens and sort of the ventral striatal targets are pretty commonly used, as well as the anterior limb of internal capsule. The bed nucleus of stria terminalis, which you can see there listed as BST, that's also been had quite a bit of evidence, and we've used all of those targets at Royal Melbourne Hospital. You can also use the inferior thalamic peduncle and also the subthalamic nucleus. It's a little bit institution dependent as to what people use, and at the moment we don't really have a good system for working out which target you would offer to which patient. So it really is a little bit dependent on the surgeon and where you would have your procedures done.
Code yellow, leaving lift out of order.
Sorry.
Code yellow, leaving lift out of order.
So, the reason why these all work probably reflects that the neurobiological underpinnings of this illness are really sort of circuitry based. So looking at these more central striatal targets and how they connect to the frontal lobes and other areas of the brain. In terms of what the actual lead looks like for DBS, you can see here on the left a picture of the tip of the lead. So you can see there are 4 little metal parts there. Those are the parts that we can program. And you can set these as either negative or positive charge, and you can see on the other pictures that actually changes how it distributes the electricity to the surrounding brain tissue. That's not so important in OCD. We really just want to capture as much of the surrounding white matter tracks as possible, and so we would tend to use the monopolar single or the monopolar 2 contacts there, so you can see, so that you get a good spread of charge. So I guess thinking about using this treatment, it seems a bit extreme. You've got to have brain surgery, obviously, to get the leads in there. It is an appropriate treatment for a proportion of patients, and know that it has, similar efficacy for reduction compared with non-surgical treatments, and all the targets seem to work. And so I guess this is sort of going over a little bit of what we've already talked about. There is about 200 to 300 cases probably that have been done for this. Most of them are reported in the literature, although some of the institutions that do this surgery probably have done additional cases that are not reported as well. And there's been, obviously initially open label studies of low case numbers, 4, 5, 6 patients, but there have been randomized controlled trials, which you can see listed here, and some meta-analyses. And all of those really show pretty similar efficacy. So most of these would show that about 60% of patients are classified as responders, and I'll talk about what that means. And the reduction in symptoms is look pretty variable, but usually between sort of 40 and 60%. Some trials have said have had higher than that, up to 70 to 80% reduction in symptoms. But to quote Dennis Valakoulis, he normally tells people that about 2/3 of patients do 2/3 well. So it's certainly not a cure by any stretch. In terms of what we mean when we say people are classified as a responder or a non-responder, so universally across the literature, this is designated as you need to have had a reduction in your severity scale, so on the Y box, of at least 35%, which doesn't sound like a lot, really. In depression studies, it's usually 50%. Why it's sort of been designated as 35 in the OCD literature, I think probably speaks to the degree of treatment resistance in this illness more broadly. So in terms of DBS for OCD in Australia, as John said, this has been happening now for about 10, 11 years. We tend to do 1 to 2 patients a year. I think so far we've done 15 and we've got another 2 lined up. There's a process involved in that. So it's not legal in every state. So you can't have this done legally in New South Wales because any sort of neurosurgery for mental illness is not legal. The program first started up at the Royal Melbourne in 2010. And I think prior to that, the more traditional psychosurgery hadn't been done since about 2000 was the last procedure for that. So there have previously been other sites in Australia that have offered this treatment. So there were some cases done at St Vincents Hospital and also with Philip Mosley up in Brisbane. It's a bit tricky in terms of how we get this stuff done, and it's often sort of relied on research funding and things. And so at the moment, actually, RMH is the only place in Australia you can continue to have DBS done for OCD, which obviously represents a huge access issue. And we do have patients from from all of the sort of eastern states and also from South Australia. In terms of how you access this, so generally people need to be referred to us to have sort of an assessment done to see if, people are suitable. And generally the criteria are that, you need to have OCD and it needs to be shown to be treatment resistant. So you need to have had at least, you need to have tried at least 3 or 4 different antidepressants at good, high doses for at least 3 months. One of those needs to include clozapine, and you need to have had augmentation therapies as well, even though we know they're not always the be-all and end-all. You also need to have had at least 2 trials of psychological treatments, and there really sort of needs to be no other major issue that's accounting for symptoms or that would get in the way of surgery, like a major substance use disorder or a psychotic illness, that sort of thing. If we think that people are appropriate, then we have to actually apply to the Mental Health Tribunal. We can't just offer people this treatment. So we put together quite a lengthy submission that documents all the previous history. It goes to a special panel at the Mental Health Tribunal that are trained specifically in this type of treatment. And then we have a hearing and the tribunal will decide if people are allowed to then proceed or not. Once we've got permission, then the patient can legally go ahead and have the surgery at any time they choose. It's not capped in terms of when they have to do it. This is sort of an update on some of the patients that we've done. A couple of the first patient we did for this actually had Tourette's as well, and we usually don't include in the results, and then the more recent one's only just been done. So you can see sort of the first 13 patients here. You can see there's probably 2 patients there that really haven't had a good response at all. One of them's had her device taken out, mainly so that she could pursue treatment with TMS, which is an absolute contraindication if you've got DBS leads in. And one of the other ones, the other person there with the negative change, their device is off at the moment. So probably 2 completely non-responders. And everyone else has largely had a response to some degree. And even though sometimes it doesn't look that striking, these patients have been able to do things that they weren't really able to do before, like working, going on overseas holidays, attending weddings, entering relationships. So sometimes the change in the Y box doesn't always reflect actually the functional improvement for these patients. This is an older graph that looked at the first 7 patients to really reflect that actually looking after these patients is not always as it's not always as straightforward as just saying, oh, it will give you a certain improvement. This is looking at people's Y box scores over time, and you can see for some people like particularly the one in red, mostly they had a good improvement from early on and they were able to sustain that. If the patient number 4 in purple, you can see there's been really wild fluctuations over time. And sometimes that's reflected external life events, but sometimes it's also to do with the nature of the stimulation and needing to review that at different times. So, obviously interpreting this sort of work in the literature is tricky because the reality is that at any given day, people might score differently on the Y box. I guess to give you a bit of an update on what has been found at the other centres in Australia. So the group up north in Brisbane that was originally set up through Rodney Marsh and taken over by Philip Mosley. So they did 9 patients using the bed nucleus ostrea terminalis as a target. And that was overall really quite successful. So the average reduction in the Y box was 16 points, which is quite a lot for a scale that's out of 40. And most of these patients who are going ahead with surgery would score sort of 30 and above. So you can imagine that's actually a pretty significant reduction. And interestingly, in their cohort, they didn't have any patients that got any significant adverse events related to stimulation. So one of the things that's quite common with deep brain stimulation, whether it's for psychiatric indications or neurological, is you can get stimulation-induced hypomania. I think we've had 3 or 4 of our patients have had that. And partly that probably reflects location, and probably it also partly reflects stimulation adjustments and things. So it's interesting to see that they didn't have any of those in their groups. And they've also done some really nice work looking at different, the connectivity of these patients from terms of where they put the leads and the different areas that this is connected to and why they think this has been beneficial, which I'll show you a bit later. And then also the St Vincents Group have also sort of reported on their 4 patients. I think they have had a bit of variability and also were pretty broad in terms of who they offered this to in terms of having other comorbidities and things, and have looked more at the sort of qualitative experience and have published on that, which is quite interesting if you're interested. I guess sort of where we're at now in this sort of journey with DBS is, I suppose, there's now been several randomized controlled trials in this and some meta-analyses, and, even though there's sort of only 200 to 300 cases perhaps in the literature, across lots of institutions around the world, the results have been pretty similar. And in Europe and the USA, this is OCD is a listed indication that you can have DBS for. And so Philip Mosley, psychiatrist in Brisbane, put this recent paper this year together in the local journal, really sort of calling for this to actually be an accepted treatment. Not that it's going to be suitable for everybody and that should necessarily be first-line treatment, but actually that if we could get this as a listed indication through, the TGA and get sort of an MBS item code, that actually this would be much more available for people. At the moment, it's really only available as an experimental treatment, unless you come to the Royal Melbourne Hospital. It's really a bit of an access issue at the moment. And so he's currently in the process of trying to apply to get this as a listed indication. But as you can imagine, there's not always a lot of buy-in to these sorts of things. We'll talk a little bit about why DBS works. So I guess what we know about OCD is sort of taken from lots of different studies, from our understanding of why people get better when we do surgery on them, and also largely imaging studies. And so really the sort of thinking is around there being probably underactivity in the sort of more central striatal targets and sort of an overactivity in this hyperconnectivity between the frontal areas. And so it's sort of viewed as a bit of a dysregulated circuit. And so it's thought that by putting DBS leads into those central areas that we can ramp those bits up to do their job in sort of surveilling the front areas and getting them to damp down a little bit. When we do DBS in OCD, you can see some acute improvements. So sometimes people improve in the first, even in first couple of weeks, but usually first couple of months. And that's thought to be kind of that that direct stimulation of, say, the nucleus accumbens or wherever you've put the actual lead in. And usually those improvements are more kind of reduction in anxiety, improvement of mood. In patients who've had DBS for depression, they often improve within a couple of weeks. So you're likely to be getting those sort of acute improvements in those areas. But what we also see when we're treating these patients over, I've looked after some of these patients now for 5 or 6 years, is that there is this change over time that probably reflects more that connectivity between the central areas and the frontal lobes and other areas involved in this. So you're getting sort of longer term changes to the circuitry. And there is imaging studies to sort of support this. Obviously, it's a pretty limited area of research when there's not a lot of patients who've undergone these treatments. And we don't always know exactly how people have made their stimulation settings. And, reflecting back on that graph that I showed you where the Y box can change quite rapidly, trying to work out what is the stimulator that's affecting things and what might just be other circumstances in people's lives. Maybe they've had a superimposed depressive episode. Obviously, teasing that all out is quite difficult. And, we don't really know which targets, which, DBS targets we should be offering to which patients, what settings we should be using. And it's sort of, you're often just going through things systematically, trying something, giving it time, turning the stimulator up, giving it a bit more time. And the other thing we don't really know is, why does DBS work where SSRIs might have failed, or why does it provide that additional benefit? And again, that probably relates to that interruption of the direct circuitry rather than sort of a more broad changing, I suppose, of the chemicals involved. I suppose, often people are a little bit nervous about DBS. Is it something that we should be offering to people? Should people be able to access it without going to the tribunal, all that sort of stuff? Could we make it a more effective treatment? Even though we know it's just as effective as all the other treatments, people are still a bit more reticent about it. And that's probably partly historical. Obviously, there's been some pretty, terrible abuses of power in psychiatry that involve neurosurgery. And so there's always this sense that we could be doing better, we could be making this treatment more effective. And I think we can. And there are a few things from my point of view that we certainly could be doing. And I think, funding and access is definitely one aspect of that. Should people who have capacity be able to access a treatment that could offer them benefit? Absolutely, they should be able to. And I think if we could get that actually approved as an indication, then that actually opens up public hospital neurosurgical departments the ability to actually fund this. And then I guess the other aspect is, can we improve how this treatment works? Can we improve our knowledge of how we make stimulation adjustments? Can we individualise this treatment? Would one person be better with a nucleus accumbens DBS stimulator put in? And, who might we offer the bed nucleus osteria terminalis to? Like, is there a phenotype that might improve better with different targets? And partly that's about, I think we need to understand better about, why does this even work? What is it? Why can we put a stimulator in 5 or 6 different places and get the same result? And that may be about, you just have to affect the circuit somewhere and it actually doesn't matter. But it also might be that, perhaps if you've got certain symptoms, that you actually do better with a certain target. We do know a little bit about the sort of phenomenology, what improves, what doesn't. It's sort of broad brush stuff. So we know that people with sort of washing contamination fears, with checking and sort of obsessions, neutralising, that sort of stuff, those sorts of symptoms do get better with DBS. We know that hoarding is something that doesn't. So if that was the primary symptom, then we typically, wouldn't offer DBS in that situation. But again, that's sort of still a fairly broad understanding. I guess, OCD is a pretty invisible illness. These patients don't, even when they're severely disabled by this illness, they're not a big burden on the health system. They often don't even seek much health support. And so that is hard to then garner interest from a industry point of view, from government point of view. These are not patients that put a big drain on bed stays. From the industry point of view, they're not going to sell a lot of devices doing this. It's a couple of patients a year at the moment. And so getting kind of people's interest to push this forward is pretty tricky. We have, however, in the last probably 12 months ago, we did manage to get support from the state government, however, to actually fund running this service. So I think, you know, it is worth persisting and, you know, trying to, you know, advocate, you know, for this to at least be available for people to access. Measuring this is harder than in movement disorders. You can have this surgery done, you can turn the stimulator on, and you might not see anything for a couple of months. And if we haven't got the settings right, then it might be another couple of months. And so it's quite hard to actually measure the benefit. It does take longer to respond, even than other psychiatric illnesses with DBS, but definitely takes longer than in movement disorders, where it might be, you know, you make a change to the stimulator and you see a fairly immediate response. And typically people's responses are distilled down to a score, you know, on the Y box. And these are patients who sort of already maxing out the Y box even when they come to see us. And so you can imagine if you're doing obsessions and compulsions for, you know, 16 hours a day, if you reduce that down to 10 or down to 8, it's a huge change, but it doesn't reflect much on the Y box. You don't get a hugely different score. But that might enable you to be able to go out with your friends or to take up exercise or to attend an important event. And those things are much more relevant to the individuals than they are to sort of how you score that response in a study. And then I guess, you know, how do we understand this better? And, you know, we really need obviously probably more imaging studies, but it's tricky to get large numbers. And then there's always the issue about how do you extrapolate that information from a group to an individual. There are some interesting studies in this space, and mostly they look at the studies that are looking about connectivity and also white matter tracks. So we can image these tracks and look at which are the ones we might be capturing, and, you know, how does that then relate to what we're doing. It's interesting stuff, often in small numbers. You can see here along the top line, this is sort of a heat map essentially of people with DBS leads in place, looking at what were the main white matter tracks that were captured in people who had the best response. And so you can see in the top row, these are the people who responded the best. And there's, you know, even eye of faith stuff, you can see, look, they probably had a little bit more of that sort of right frontal white matter tracks captured. And that's been sort of represented in other studies as well since that time. There's a group in Germany who've had a look at this and found sort of similar things. Basically, they had a group of patients that they had done the white matter tract imaging on, and they found again that right sort of medial frontal areas and the left anterior cingulate were the areas that sort of in the patients who did the best. And they actually were then able to model in the ones who hadn't had the imaging that actually they could predict which patients would get better and which ones wouldn't, which was quite interesting. You can see here they sort of modelled this. You can see this in the blue here is that sort of medial frontal gyrus in the frontal lobes, and the little red dot is kind of the area of tissue that's being stimulated by the deep brain stimulating leads, and the tracks that then connect between that central red dot and the blue part in the frontal lobes. And you can see that there is a correlation between how connected the DBS leads are to those frontal areas and the degree that you improve on your Y box. And so I think this sort of imaging, you know, and these sorts of studies are really important to help us try and understand, and also then we can start to work out, well, where should we be putting the stimulator? Can we actually do this imaging first and create a kind of a map or a plan before we put the leads in, so that we make sure we put it in the right place that is most likely to give a benefit. So I think that's sort of, you know, where we're heading as our technology and things improve. This is just to give you a bit of an idea. I think this is probably from the German study, that you can see where all the leads were of all the different patients. So they've imposed this into sort of just onto one brain map. So you can see they're sort of all largely in the same region, and you can see those little grey dots is where the stimulation would actually occur. And these are the large white matter tracks that are then captured by the stimulation. So that one in the red is the the one that projects through to that right medial frontal gyrus area. Locally, so there's been some interesting studies looking at this. This is from Phil's group up in Queensland, and they looked at, again, the connectivity to kind of those frontal areas, and you can see a heat map. This one's a little bit more scattered, and you sort of have to look at and believe the stats. But you can see that again in B here, you can see there's that sort of right frontal areas that seem to be quite important. And again, on the correlation graph here, you can see it does seem to correlate with how strongly it's connected to those areas as to how much people improve. This is a really interesting patient that we had at Royal Melbourne, and she was a lady in her 60s who'd actually undergone bilateral leukotomies in the 70s at Chelmsford Hospital in New South Wales. And she had had these done separately. I think she had one done in 1970 and one done in 1973. And it had really obliterated a lot of her frontal lobes. And she didn't get a lot of benefit to her OCD. It helped her anxiety, but it really didn't improve her OCD. And she came to us seeking out DBS, which you can imagine we're a little bit, I guess, unsure about. Like, could we offer this to this woman and actually say, look, we think it might or it might not actually give you improvement? And so we did a little bit of imaging work on this woman to see, well, what tracks are left if we think that this works by affecting the white matter tracks to connecting the frontal lobes? Like, are there actually any of those left in this woman's brain because it's been so heavily damaged? And so what we did is we modelled all the different targets that we offer at Royal Melbourne to see what's possible. And on the left here, you can see, so normally we were doing the nucleus accumbens or the bed nucleus ostrea terminalis, so the pink or the red. And you can see they don't really capture many of the fibres coming forward to the front, which are the green ones. And so we sort of thought, well, if we put our leads there where we normally put them, probably it's not going to do anything. I mean, obviously we don't know that, but, you know, we thought, oh, you know, perhaps we need to look at using a different target. The VCVS is a fairly commonly used target in the literature, but again, it sort of didn't look like it was capturing the right fibres. And so in the end, we offered her a GPI, which is, see this yellow, the yellow dot, and that seemed to sit right in the middle of this white matter tract that was left for her on the right. There wasn't a lot on the left, but we thought it was probably a reasonable thing to say to her, look, we don't know if this is going to help you, but you know, we think that it's a possibility and it's up to you. And look, she decided to go ahead because she felt that her OCD continued to really afflict her on a day-to-day basis. And interestingly, this woman actually has done the best out of all of our patients and had about a 65% reduction in her OCD symptoms, to the point that I only looked after her for about a year and I've not seen her very much since, occasional phone calls, but she's basically doing really well. So it's, you know, obviously didn't need much in the way of sort of frontal tracts still present, but it was enough for her OCD to still be really present, and probably, you know, those circuits remained kind of dysregulated. This is another patient of ours who we used this imaging to help us work out which bit to stimulate. So really just the top left pictures are the most interesting, I think. You can see sort of on the top, very top left, and below that, we looked at whether we stimulated the most distal electrodes, so the bottom two. Would that capture those frontal tracts? And it didn't really look like it would. And when we modelled looking at the most proximal, so the top two, you can see there's these much thicker green tracks there going to the frontal lobes. And so those have been the ones that we've predominantly used. And we were able to get benefit for her within the first 12 weeks of treating her. And that's been maintained actually throughout the course of her treatment over many years, which has been really good. So it looks like there are some questions which I'll open up. This is a quote from one of our patients to give you a bit of a sense, you know, about what the real world impact is. Yeah, so I'll read through the questions that we already have, and then if there's any others, you can obviously pop them in there or in the chat. So somebody wanted to know, are there tribunals involved for other indications of DBS, especially Tourette's? So the answer is that they are involved not for Tourette's. So Tourette's is designated as a neurological disorder, and you do not need to go to the tribunal. And so that is a really interesting divide, that OCD falls on the psychiatric side of the line and Tourette's on the neurological side. For other psychiatric indications, they're all in the experimental realm, I suppose, in terms of depression, eating disorders, those sorts of things. And yes, you absolutely need to go to the tribunal for those. But yeah, any other neurological ones you don't, and Tourette's is deemed to be neurological. Another person has asked, what is the mechanism by which atypical antipsychotics assist in the treatment of OCD, and so why can clozapine make it worse? The antipsychotics that help in OCD are really primarily the ones that have high affinity for the D2 receptor. The haloperidol, risperidone, aripiprazole, those ones probably work better. Olanzapine probably still enough to get a reasonable benefit. Quetiapine, not particularly, doesn't seem to help very much. And we know that clozapine's really very low affinity for the D2 receptor, which is probably why it doesn't help. In terms of making it worse, I'm not completely across that, but we know that it certainly does, and as can also high-dose mirtazapine can also do the same thing. And I imagine that's probably more related to some of the other receptor groups, presumably some of the in some of the specific serotonergic ones, but I'm not 100% across that. Dharma, thanks Dharma. Dharma's asked, do we need to go beyond the Y box to capture other important crucial data, and is anyone doing this? So functional measures, looking at loss and regain of functioning income, and qualitative studies. So yeah, we absolutely do. Even in terms of severity, measuring severity, the Y box is pretty limited in this group where they're quite treatment resistant. So as I was saying before, these patients probably, there's a ceiling and they're well past it. And so even when we give them benefit with DBS, we're not probably capturing it very accurately on the Y box. But having said that, it's such a well-validated measure and it's what we have and what everyone uses. So I think we definitely have to keep using that. But it's certainly been commented on in this field that it feels a bit inadequate. There is other data. We use a DAS, depression, anxiety, stress scale. That broadly does improve, although it doesn't necessarily seem to be linked to improvement in OCD all the time. We also used a SOFUS, which is like a measure of socio-occupational functioning, and in our group there was statistically significant improvements in that as well as in the Y box. So those were the two things that did improve. There are groups of people, so Frederick Gilbert from University of Tassie and others who are looking at more qualitative stuff, and we've got a psychiatric trainee, Zara, who's actually doing a study in this in our with both our patients and Philip Mosley's patients to look at sort of really qualitative stuff. So having interviews with patients and their carers to look at what impact DBS has had on their life, how it's sort of how people feel it's changed maybe their sense of themselves or their identity. And there is certainly work in this space, predominantly in the Parkinson's area, but also in OCD and other groups. There is sort of talk about, the burden of normality in this group. So as people improve, how that impacts on both them, but also the roles, carer roles, sick roles within the family. And so there's definitely work in that space. And in the Parkinson's group, there's quite a lot of work around the impact on identity and how having a DBS stimulator in situ actually impacts on your sense of yourself, both pre and post DBS. I think in my sense is that in Parkinson's, that probably is a bit different because people have quite a visible disability that responds, if it works well, quite quickly to the treatment. And so they go from having quite impaired function to all of a sudden having a, potentially large improvement, whereas I think in OCD it is a bit more gradual. And the other thing we definitely need to do, I think, is around some health economic data. So looking at capturing measures that we can use to show that actually it is a worthwhile thing to do at a economic level to try and get the government and other people to be a bit more interested. I think there's a little bit of research on that, and overall it shows that actually, even though it's a reasonably costly intervention, it is actually economic to do it. Somebody else has asked, are there any specific augmenting agents that are required to be trialled? Yeah, so there's no hard and fast rules about that. If people hadn't tried any and they'd only tried SSRIs, then I would usually tell them to go and try a few things. I think it's reasonable just to probably try one antipsychotic, and I would often get people to try something like aripiprazole, mainly because the side effect profile's obviously much better than giving somebody olanzapine, and for what's likely to be a pretty small benefit. You get a sense when you're meeting these patients that they're really treatment resistant, and adding an antipsychotic's unlikely to be make or break in terms of improving their illness. There are some other augmenting agents that have a smaller body of evidence, but they each have randomized controlled trial evidence, and I think are actually a bit more impressive in terms of the reduction in symptoms, and also just anecdotally in my own sort of clinical experience. And so those ones are topiramate, lamotrigine, pregabalin, and there is some evidence for using memantine as well. And each of those obviously have pros and cons, but largely the side effect profile is a bit better than things like olanzapine and quetiapine. And they have sort of a more like a 40 to 50% reduction in symptoms across those trials. So there's less of those trials, but the effect is a bit more compelling. So I'll often suggest that to people as well, that those are things they can try. Because the process is pretty lengthy, in terms of, coming to see, us at Neuropsychiatry, getting it all put together, deciding if people want to go ahead, and then waiting for a tribunal date. Often people can try this stuff while we prepare the application, and we have done that on occasions. If we've thought that, people haven't really tried ERP and they sort of need to get the application over the line, we'll say, look, you go and do it. We'll prepare this, prepare the application, and then we'll see where we're up to. The lady who'd had the leukotomies, she had not had enough treatments really to get the application over the line. So she'd had no augmentation. And so she came for an initial assessment with me as an outpatient, and I sort of let her know, look, really, you have to have at least tried something else. And so she went away and tried a couple of things that I suggested with her treating psychiatrist. They didn't make any difference, and she came back a year later. And then we ultimately did proceed to DBS. The tribunal are much more comfortable with this treatment now. So their view is actually not that this is necessarily a treatment of last resort. And so they're not really pedantic about what you have and haven't tried, which is good from my point of view. Hi, Cav. There seems to be a push, Cav's asked, there seems to be a push towards using neurocognitive tasks and symptom provocation response to capture effects in a more objective manner. Is this something you've looked into? I have not, we haven't done this. Yes, this is something we've looked into. We've got some CANTAB tasks, so sort of computerized neurocognitive tasks that we have started to do. It's been a little bit done in a bit of a haphazard manner, but certainly we've looked at this sort of pre-stimulation and post-stimulation, and certainly people do improve in terms of they're mostly frontal and orbitofrontal tasks, so looking at gambling tasks, and people are able to, once you treat their OCD, are able to take sort of bigger but also more appropriate risks, and they're able to delay their decision making a bit better, which is quite interesting. And they also are able to do set shifting, so where you go from sort of one set of rules to another set of rules, they can do that much more quickly and accurately as well. And then some other interesting tasks that we looked at, sort of spatial working memory and other things that those also improve. We also do neuropsychology assessments at baseline and about 1 year later, and that includes a PAI, so a personality assessment inventory, and the results of that's really interesting. So there is a neurocognitive profile, I suppose, that you see in OCD, and it's largely around people's processing speed's really slow because they're just doing so much other stuff in their head, and that has sort of downstream effects on, you know, memory and other things. And there's definitely some executive change that you see. So what we've seen in our patients is that improves, so they get quicker and they're able to shift from sets of rules more quickly and more accurately. But the other really interesting thing that we found, and this hasn't been published yet, but one of our neuropsychologists is looking at this, is actually their personality profiles normalize. So the interesting things about it were that the personality profiles all looked quite similar in terms of the data, which for me, knowing these actual patients, I wouldn't necessarily say they had similar personality styles. And actually they had lots of, you know, aspects around anxiety and different subscales on that were really out in the extreme range, and that actually normalizes. So that's been a really interesting finding as well. I do think what hasn't been done is probably looking at using neurocognitive tasks, as you say, Kath, as more of a actually looking at how the DBS works. Is it working effectively? But I think that is absolutely something we should be doing. Somebody else has asked, is dementia an exclusion criterion? Look, probably. Look, I think there are some studies looking at using DBS for treatment in dementia. I think we would see that in this situation as probably an exclusion criteria. There is, I mean, not so much in OCD, but certainly from evidence in the Parkinson's literature, typically where there's cognitive impairment actually usually predicts a poor outcome from DBS in those situations. So I think it's tricky. There's also obviously potentially issues around capacity in terms of being able to consent to a pretty complex, you know, procedure. So look, I think we would, unless it was sort of very early, I think that probably would be an exclusion, generally speaking. But look, you know, there's obviously treatments like something like memantine that might benefit both. So I think, you know, it's certainly, there's always ways to be creative with treatment. I'm just going to jump over to the chat because there's also some stuff in there. Oh, great. Hi, Peter. That is great to have you on board. So Peter Bosnack is a psychiatrist at St Vincents, and he's just letting us know they've done 8 DBS participants to date. Fantastic. My understanding from last time we caught up with Peter is that their results have been largely similar to ours. So, you know, that it had been efficacious. Tom Rigo, hi Tom. He has asked how reversible is the DBS operation or how difficult is removal of the leads? Does that ever happen in the Parkinson's group? Yep, so it's actually largely pretty reversible. So there are a few different types of neurosurgery you can have for both neurological and OCD or sort of psychiatric indications. So DBS is only one of them. You can also have sort of MR focused ultrasound and gamma knife radiosurgery. The difference with those latter two is that they're actually lesional procedures. They're non-invasive, so you don't have to actually, you know, have your skull opened up to have them, but they cause a lesion, even though it's small. So those are non-invasive but irreversible procedures. DBS is obviously invasive. You have to have burr holes and, you know, brain surgery, but it's actually largely pretty reversible. We've had one of our patients who, so the first patient that was done at Royal Melbourne actually has had 2 DBS procedures. So on the first one actually had, I think, 4 leads put in, and that didn't result in any benefit, and they were ultimately taken out and replaced. And actually you can hardly see, so she was had an MRI brain scan done in between, and actually you can hardly see, there's like a very faint scar essentially on the MRI, but it's largely reversible, and obviously the stimulation is reversible. So you can turn it off and on and up and down and change the setup of this of which contact points you're stimulating, and so the stimulation-induced side effects are also reversible. So if you do get a hypomania, generally the treatment is to turn the stimulator down, and often that's sufficient to sort it out. Dennis has also just pointed out that the tribunal process requires informed consent. Yep. So even though we're going to the tribunal, this is not an involuntary procedure ever. You need to be a voluntary patient, and part of the criteria is that you can provide informed consent. Sam has asked about clozapine-induced resistant OCD, where you can't stop the clozapine. Any comment on DBS? Yeah. Doing DBS in patients with schizophrenia is something that's not really been done much. There are cases around, but most people, I think, would feel fairly a bit trepidatious about doing DBS on patients with schizophrenia. I think that's largely been around, partly sort of the Parkinson's literature, but also I guess just in general that, we can induce, hypomania, mania, psychosis in these patients. And that probably is more largely drawn from the Parkinson's literature, that you can get quite good going psychotic episodes that are stimulation induced. And it also can increase impulsivity. So I guess around issues with suicidality and harm and things is, it's pretty tricky. I think we'd be generally pretty resistant to doing DBS in that situation. Yeah. But certainly I would, in those patients, advocate for trying some of the less well-known augmentation agents. So pregabalin and lamotrigine are probably my two favourites. And you typically need about 225 to 300 of Lyrica and about 150 to 200 of lamotrigine generally. Dennis has added that historically the tribunal would not consider schizophrenia for surgery. Has not been tested locally with DBS, and there's limited evidence plus. So, yeah. I think there would be a couple of patients in the Parkinson's group that have had DBS with schizophrenia, but I think these are patients who would not be our typical community mental health team schizophrenia patients, basically. Just checking back and forth to make sure I haven't missed any questions. I think I haven't. Obviously, if there's any other questions, jump on and pop them in. John?
We're coming close to time anyway, Sarah, so perhaps we'll stop it there. And thanks everyone for the questions and comments, and thank you, Sarah, for a fascinating talk. Look out for a recording of this talk, and in the coming weeks and into next year we'll be releasing the program of speakers, probably starting in February, as is usually the case with these sorts of talks. So thanks again, Sarah, and thanks everyone.
Thanks, John.